So let me move to starting it off with introducing our first two speakers. And one is Doug Jacobs, who is the co-director of this course and is a recognized expert in suicide assessment and intervention. After editing the official Harvard textbook, the Harvard Medical School Guide to Suicide Assessment and Intervention, he was appointed chair of the work group that published the APA's, American Psychiatric Association's, practice guidelines for the assessment and treatment of patients with suicidal behavior. Based upon this work, Dr. Jacobs developed the widely used suicide assessment protocol, the SAFE, S-A-F-E-T, -T, which he will be talking to us about today. And I'm delighted also to present Carson Sulzer, who's a graduate of the Harvard Psychiatry Residency Program and recently joined the staff of the Mass General Hospital Department of Psychiatry, working with their team-based outpatient psychiatry clinic, and now a member of the Harvard Medical School faculty. Her clinical interests lie particularly in suicide and trauma and stressor-related disorders. She was instrumental in the integration of the SAFE-T into an EMR, an electronic medical record, which she will present on today. So let me turn it over to Doug and Carson. Go ahead, folks.
Thank you very much, Alan. And on behalf of McLean, I want to acknowledge our chair, Dr. Scott Rausch, without whose support this program would not be possible. Today, we're going to be talking about the safety protocol, how it's been integrated into an EMR, and with an assignment of suicide risk. The first two slides highlight why we're doing this course. Unfortunately, suicides have continued to rise, such that there are nearly 50,000 suicides in the U.S. In 2022, which is a 3% increase compared to 2021. There have been the largest increases have been seen in older adults, primarily those over the age of 45. There has been some good news, a drop in youth suicides. Perhaps this is due to the increased attention to youth mental health issues. These next two figures really highlight the challenges we have as clinicians. It is believed that over 12 million adults experience serious suicidal thoughts. 3.5 million adults have made a suicide plan, and 1.7 million have made a non-fatal suicide attempt. The underlying factors include psychiatric illness, relationship problems, recent psychosocial issues, and importantly, intolerable mental pain, which is really one of the hallmarks in assessing someone for suicide risk. Only 3 out of 4 persons who died by suicide, 3 out of 4 were not in treatment at the time of the death, and 50% never had psychiatric contact. In terms of the next slide, it is psychiatric illness which is connected to suicide, nearly 90 to 95%, with 50 to 70% having major affective disorder. The gender ratio is 4 to 1 male to female for suicides, and the opposite for suicide attempts. This next figure is alarming in that 60% are believed to die on the first attempt, which I will be talking about in this presentation about how we can think about that. 55% die by firearms, 70% communicate intention to significant other. And the point here is that this is why talking with collateral contacts, particularly family members, can be highly significant. And we believe that about 5% of suicides occur in hospital setting and grounds. The major risk of that group are really our psychotic patients, which Dr. Unger will be talking about. So the objectives today are to understand the components of a suicide assessment and the role of clinical judgment, to identify clinical features and symptoms that extend beyond traditional risk factors that can assist in short-term risk assessment, and to demonstrate the integration of the safety protocol with it an EMR, EPIC, and we will be introducing a model for the clinical assessment of suicide risk. So in thinking about a suicide assessment, it is the estimation of suicide risk at the culmination of the suicide assessment. It is the quintessential clinical judgment, since no study has identified one specific risk factor or set of risk factors as specifically predictive of suicide or other suicidal behavior. These next two slides show why prediction is not possible. This slide demonstrates that persons with suicide risk are many times the risk of suicide for persons without suicidal ideation. However, if we look at the population of suicidal ideation, which is really a population that we treat, as the next slide shows, you can see that the outcome is less than 0.4%. And that's just important as we're trying to really both look at a risk factor and yet the limits we have in terms of prediction. The next slide really comes from the DSM-5, and it's really to highlight that it's not formal diagnoses that are critical, but rather to demonstrate that the need for treatment is a complex clinical decision that takes into account symptom severity, such as the presence of suicidal ideation and the patient's distress, mental pain, which is particularly relevant for us assessing patients who are at risk for suicide. So therefore, we don't limit our treatment as to whether or not someone satisfies criteria for a formal diagnosis. The next slide outlines the 5 steps of the safety. I developed this in 2006 with a grant from SAMHSA. It is in the public domain. The QR code will give you access to download the card, but the 5 steps include identifying risk factors, protective factors, conducting a specific suicide inquiry, determining the level of risk, and then choose appropriate intervention, and then documentation, which will be highlighted with Donna Vanderpool in her talk. So in thinking about suicide, I want people to think of a clinical perspective. There's many elements here, and just to highlight, in the center is psychiatric illness, substance disorder and use, the specific suicide symptoms, which I will be highlighting, and on the bottom is really suicidality. These other components are relevant, and today Dr. Bunny will be talking about the neurobiology. So in terms of this notion of the lack of predictability, I refer to a massive meta-analysis that was done in 2016, which reviewed nearly 2,500 papers and only 365 met the criteria. And it does state that the prediction of suicidal thoughts and behaviors based upon risk factors have not improved in 50 years. Prediction is only slightly better than chance. And the literature is really probably most useful in evaluating long-term risk. However, and this is important, the results do not mean that the widely used risk guidelines for suicidal thoughts and behaviors are invalid or useless, given that the top 3 categories for suicide death included prior psychiatric hospitalization, prior suicide attempts, and ideation. So how do we go beyond traditional risk factors? And I'm going to refer to a landmark study that was done years ago and a a theory presented by Dr. Joyner. So this landmark study from 1972 to 1978 to 1982 consisted of 954 patients with major affective disorder that examined suicides within the 1 year of enrollment and contrasted it with clinical features observed in those suicides that occurred 2 to 10 years after clinical enrollment. And this is really important because we're trying to really look at how can we assess short-term risk. So the features identified for early suicide were psychic anxiety, panic attacks, anhedonia, moderate alcohol abuse, and global insomnia. Suicidal thoughts and behaviors, not that they are obviously irrelevant, but they're more correlated with later term risk. The theory of Dr. Joyner, which is called the interpersonal theory of suicide, really highlights a central question. Why do people die by suicide? Because they can and because they want to. And this may sound somewhat flip, but it's looking at both someone having the desire and capability. So desire, according to Dr. Joyner, which I think I happen to espouse to, talks about thwarted belongingness, the need to belong and the desire for connection, and the perceived burdensomeness, people who feel that they are a burden to others. This has to be connected. Suicides happen when there's a capability. And what does he mean by that? It's the habituation to or tolerance of pain, particularly as it relates to prior and repeated attempts. And one of the elements here is a fearlessness, the loss of the fear of death, and that can be manifested by actual attempts, aborted attempts, and a term that he refers to is mental practice. And I really want to highlight that and focus on this next slide, because it's a term I've been doing this work for years, which I had not really considered. And it's a vivid preoccupation regarding one's suicide, which represents a form of mental practice. It involves seeing one's death by suicide in their mind's eye, and watching a clear and vivid video of their own death. This may be helpful in understanding and assessing those at risk of dying of suicide on their first attempt. And I will be emphasizing this again in other slides, but it's a concept so when you're examining someone, not just asking about suicidal thoughts, but asking, can they see their own death? Can they view it? So going on to the next slide. So what are the suicide-specific symptoms and attitudes? Intolerable mental pain, thwarted belongingness, feeling like a burden, loss of fear of death, anhedonia, global insomnia, severe psychic anxiety, panic attacks, lack of remorse following attempt. And again, this is an important question when someone has made an attempt. Are they sorry that they survived, or do they have remorse, feeling entrapped? And then I put in mental practice, and you can see I have highlighted here, don't be misled by future planning. Unfortunately, people can do two things at the same time. They can be thinking about their future and thinking about their own death. And this highlights the psychological phenomena of ambivalence. In terms of protective factors, which we need to take into consideration, and really thinking about it for reasons of living, whether it's sense of responsibility to family, coping skills, fear of social disapproval, or religious beliefs. It is part of the suicide assessment. The next slide is the specific suicide inquiry. And I've addressed some of this earlier, looking at suicide-specific symptoms, ideation with mental practice, suicide plans, including researching of methods, preparatory behaviors, and aborted suicides, which is when no physical damage has occurred, distinguish self versus interrupted aborted attempts. And in suicide attempts, look at the intent versus medical lethality, the first episode of suicidality, any changes in the nature or method of the lethality, and the psychological pain history. The next slide, I'm going to turn this over to Dr. Sulzer, who has been instrumental in the integration of the safety protocol into EPIC.
Hi, everyone. Thank you for having us today and joining us here. So I just wanted to briefly go over our work with the EPIC electronic medical record. So we've been collaborating over about a year, I would say, with the EPIC Suicide Prevention Work Group to incorporate the safety protocol as a risk assessment tool within EPIC. And over the last year, we've been extensively reviewing the more recent literature to guide inclusion of additional components to the safety to keep it as comprehensive and relevant to the current situation as possible. So here I wanted to share some screenshots of the prototype that EPIC has given us. We're hoping this will go live at some point in 2024. Unfortunately, we were not able to provide an interactive form, but I think this will demonstrate enough that you'll get an idea of what we were going for. So I'd like you to notice that at the top, we have our risk factors and our psychiatric disorders. And we also have some subsections that are expandable and collapsible based on which sections are selected. So you'll see that we have the mood disorder highlighted as red, meaning it is positive in this patient. And it will open up a subsection where you may select major depressive disorder, bipolar disorders, substance-induced mood disorders to provide additional relevant information to the case. And I'd also like to highlight here towards the bottom of the slide that we also have a key clinical considerations section. This is going to include multiple of our suicide-specific symptoms that Dr. Jacobs has addressed earlier. And these also have some of the expandable and collapsible features, allowing you to provide detail of the patient as you feel is clinically necessary. Each of the sections will also have a free text box where you can either comment further upon the selections that you made or add in additional things that you think are relevant to that case. We also decided to include a homicide and violence inquiry section, which is not a portion of the initial safety protocol. However, we thought it was important to include it just to have a more comprehensive safety evaluation that could be used as kind of a standalone method in the emergency room, on psychiatric admission, in outpatient situations where we have a full kind of comprehensive picture of the patient. And obviously, this is not including the entire form. That would be much too long for today's session. But at the very bottom of the form, we ask you to select their risk level. That would be low, moderate, high. And this is entirely going to be based on your clinical judgment. There's no scoring system. It's not based on a certain number of risk or protective factors, but just your clinical judgment, which we will talk about further. And after selecting the risk, we would ask you to select any treatment interventions, safety considerations, or lethal means instructions. And these are just giving you some guidance as far as some options, but there will also be free text boxes to include additional information. And then lastly, we will ask you to, in the free text box, provide your rationale for your risk level and your treatment interventions. And I will pass the talk back to Dr. Jacobs to give you an example of a model that you might use to assign the level of risk.
Yeah, so when we're thinking about suicide risk, it is, as we've indicated, it's based upon clinical judgment. The three main areas are specific suicide inquiry, specific suicide symptoms, and the relevant risk and protective factors. And we've set up a diagram here to kind of emphasize this. So in thinking through this, we wanted to introduce a protocol for people to think about. And that's entitled the CARES 8. And the CARE stands for the clinical assignment for the risk estimate of suicide, and there are 8 elements to consider that are listed on this slide. And if we move to the next slide, there's a lot here, and I know people will want to see all that's on here, but if you think about the 3 top components: psychiatric disorders, suicidality, and suicide-specific symptoms, including psychological pain. And then these other components: the reasons for living, the status of important connections, where they are in psychiatric treatment, particularly the post-hospitalization period, psychosocial stressors, and then access to lethal methods. This provides an overview for how to assign risk. And I wish I could give you a score or a quote, an easy guide to follow. This is the hallmark of clinical judgment. So, for example, someone could have one element, and I want to stick with this mental practice in the context of depression that can overwhelm them, and it's something to think about, and they could be at high risk, where someone could have multiple factors and be at moderate risk, but that ultimately will be your judgment. I did want to close this talk with something from a study that was done many years ago about the Golden Gate Bridge. Yes, it's been known as a kind of a suicide magnet, averaging about 30 suicides a year since it was first introduced in 1936. The lethality is quite high. However, this study, which I encourage people to take a look at, they followed over a 35-year period. They followed 525 aborted attempters, and and people who were stopped either themselves, by the police, by bystanders, and the overwhelming numbers did not go on to die by suicide over a 26-year period. And this really emphasizes and maybe destroys the myth that if you stop someone from suiciding, they will find another way. And I think the reason I close with this is because our goal is to intervene and avert a suicide the best way we can. And the important point is that it does make a difference. Even the most highly suicidal person is ambivalent, and if we can get to them, more than likely they will not go on to suicide in later life. Hopefully, but it's certainly not. It really addresses this myth. So I want to close at this point, and I know we're going to entertain some questions. And thank you.
Yeah, thank you, Doug, and thank you, Carson. We're going to jump in here with some questions from our audience members. A number are coming in. Let me start with this. Is this what we're talking about here built into all versions of Epic, or only the behavioral health version of the platform?
So it would be an optional selection for, I believe, mostly the behavioral health sections of Epic. It's not something that we would expect, like an emergency room physician that's evaluating somebody to be performing the safety. It's a bit of a higher level kind of need to be a psychiatric provider to really engage with it appropriately. The suicide screen used in emergency rooms would typically be like the Columbia scale. And if that was positive, would likely be a referral to a psychiatrist who could then go on to use the safety.
One of our attendees would like to know who is expected to complete this evaluation in the system.
So this could be any psychiatric clinical provider. So we've really made it so it could be kind of psychiatrists, social workers, psychologists, anybody that's trained in the assessment of suicide would be able to complete this form.
Is this available for other EMR platforms aside from Epic?
Not currently.
Here's another question that came in. Are there any mechanisms built into the EMR to help support the increased risk of suicidality within the LGBTQ plus community?
I think other than, that's an important question, because that the LGBTQ community is at higher risk, and we identify that in the platform, so that there will be attention drawn to that population as part of a suicide assessment.
Is this intended to replace other assessment tools, or will it be used alongside something like the SRA tool for suicide risk assessment?
Again, it's part of Epic, I think, has different options. So I'm not sure whether it's designed to replace, but it certainly will be an option for a hospital or a system to choose from.
Okay, another very specific question for you. Can you speak to how the CARE S8 is similar or different from the CSSRS framework / protocol?
The CSSRS, I think probably the lifetime version, includes many of the elements, but the CARES 8, I think, focuses. First of all, it builds upon the safety, and it includes suicide-specific symptoms that go beyond the suicidal thoughts and behaviors that are part of the CSSRS, and so that's, I think, how it differs, and it just expands upon it. I think both are useful, but I think the CARES 8, introduces certain elements that are based upon the safety.
How long does the assessment actually take?
That's a good question. Having worked in an emergency room in the early part of my career, where we examined many patients, sometimes an assessment can take 5 minutes. Sometimes, though, a detailed assessment in an outpatient setting and in an emergency room can take. I don't want to be flip, but at the end of the day, the way I look at it, the assessment should take as long as is necessary for the clinician to feel comfortable that they have come up with their risk assessment. I know we are limited to time in terms of how many patients one may see in a day, but that's my view when you're doing a suicide risk assessment and you're concerned about the patient.
A quick follow-up to that. Is the assessment the same for adults as it is for children and adolescents?
I want to sort of yes and no, Jeff, in the sense that there are certain features that, particularly when one is assessing suicide risk in young people, particularly areas of irritability, their communications with others, where they are and the family dynamics may be more require more sort of examination, but the presence of a disorder, whether it's depression or psychosis, the thoughts about suicide. One of the challenges with young people is that there is a higher incidence of suicidal thinking in young people in compared to adults. So it places sort of a further emphasis on the need to really go deep with a young person.
All kinds of questions coming in for you too. How about this one? What do you consider the proper level of education for administering the safety?
It is designed for a mental health clinician, I am thinking about a practicing mental health clinician, whether it's a social worker, a nurse practitioner, psychologist, psychiatrist. I think at that level, I think it's beyond what would be expected of an educator in a school system. Although certainly the principles of understanding risk factors and perhaps when to refer for a fuller evaluation is useful to consider.
Question here. Columbia developed the Safety with CSSRS as one single assessment process. Is the recommendation to use the safety independently from the CSSRS?
I think that depends upon a system. The Columbia scale is an excellent scale that focuses on suicidal thoughts and behaviors. That is built into the safety, and that the third step is a suicide inquiry. And I think that's how the two are used together. One can choose to, when it comes to the suicide inquiry, someone can choose to use the Columbia scale. The point that I make is that the emphasis on, and again, not to belabor this, but the whole point of mental practice is a concept that I really want people to be left with.
Could this protocol be used by those who staff crisis centers?
There's a lot to it. I think if a crisis center has the time, crisis centers primarily use the Columbia scale, but I think I may defer that question to Dr. Murphy, who will be talking next about crisis assessments to really sort of fully respond to an important question.
Doug and Carson, our thanks to both of you for a great presentation.